my God.
Don't get him started.
My dad would be your nightmare patient.
Should it be that easy to pop the eye out like that?
Yep, popped up pretty good.
There definitely have been some very grotesque things on my
And
phone.
the next thing you know, it incubated in there for like 3 or 4 weeks, and it's now a massive ulcer.
We got the Ebola patient like 2 blocks from where I live. Okay, here we go.
We're back today with another episode of Eye to Eye. Alongside me, as always, is Amanda, and we have a new guest with us today, Dr. Matthew Pieters. Dr. Pieters is one of the newest additions to the Fraser Eyecare team. He is an amazing ophthalmologist, and he focuses on anterior segment surgery. He brings a wealth of clinical knowledge and surgical expertise to the discussion. Welcome, Dr. Pieters.
Thank you for having me.
Welcome.
What's your specialty and what's your role at Fraser Eye?
So I am a comprehensive ophthalmologist. So in terms of like medical management, kind of everything, I feel a lot like a quarterback. So a lot of add-ons pretty much regardless of what it is, whether it's retinal or neuro-ophthalmology or anything really gets put on the schedule. And then a lot of that I end up taking care of myself, whether it's glaucoma, whether it's retina, whether it's neuro-ophthalmology. But then if it's something that's above my pay grade or we need to nail down a diagnosis or we need different testing or different expertise, I try to make sure that I can get those people to where they need to go. And at Fraser, almost all the time, outside of like some rare pediatric retinal exceptions, we can get someone to where they need to go within Fraser. So seeing basically anything that walks through the door, and then for a handful of people figuring out kind of do they need more specialized care. But a lot of it, the medical management is something that I feel comfortable with. And then surgically, it's anterior segment, which is a lot of cataract surgery. So there are a lot of lasers that you'll do for treatments of glaucoma, kind of after cataract care, but surgically the big thing is cataract surgery.
And can you define like truly what is anterior segment surgery then?
So it is essentially anything that is in front of or at the same level of the lens, and different people will do different things. So in my sense, that's a lot of cataract surgery. You can also do some kind of minimally invasive glaucoma procedures, which is called MIGS. And so for patients who have some level of glaucoma and cataracts at the same time, you can do combination surgeries to help with that. Now, there are exceedingly more invasive glaucoma surgeries that would also kind of be in the anterior segment, but I'll leave those to our glaucoma specialists like Dr. Basha. And in theory, some corneal procedures will be anterior segment as well. So if you're doing different types of corneal transplants, that would be anterior segment. But again, we're lucky enough to have 2 corneal specialists in our practice. So for those patients who actually need a physical transplant in the anterior segment in front of that lens, we have specialists for that. But a lot of things in that area. And then there's definitely like the random things. So I had a gentleman who was like grinding rocks, and like a rock flew into his eye, and it was just there. And for whatever reason, his body like didn't notice it until 5 years later. And then so we had to open up his eye and get the rock out.
It was embedded in his iris.
And it was in his anterior segment, so that was anterior segment surgery. Now, most of anterior segment surgery is just cataract surgery, but like that would be an example of that's my little realm of the eye. And so, okay, we're going to open it up and take out this rock.
What do you enjoy most about your job?
A few things. I think generally, and I don't know if I knew this when I picked ophthalmology, but I think on like a subconscious level, I kind of felt it. I think I do best and I'm happiest when I work with people who are motivated to work with me. In ophthalmology, it's almost 9 out of 10 people like really are invested in coming in because they very much care about their vision, and you're not fighting people to do things. People like very much want to be there and they want to hear what you have to say. And like a lot of the people you can tell, especially in our Port Huron office, like these are people who will avoid going to the doctor at all costs for almost anything that isn't their vision. But then when it's their eye, they want to be seen, they want to hear what you have to say, and they listen to you. And thankfully for cataract surgery, it's a really successful and pretty low stress thing, so people get really nice results. So the combination of those 2 things is what I really like about what I do for work.
Yeah, and they get the wow factor too afterwards. I mean, they definitely notice, especially when you do one eye and the other one's still waiting to be done.
Yeah.
They could tell the difference, color's better, vision's way clear, and they're way more motivated to have that second surgery done.
Yeah, it's very cool.
So if you weren't a doctor, what do you think you'd be doing right now?
Oh, man. I really don't know. A lot of my family members are in medicine. Like when I was in college, I thought about oh, am I going to rebel and do something different? I was always more science oriented, so it was always going to be something in that realm. I did some engineering things. It just didn't do it for me. Like, so I think in another world, I could have done something more engineering based, but I just don't think I would have enjoyed it as much as ophthalmology. Now, that being said, I really do think that like ophthalmology was the field for me. I really don't think I could have done anything different.
What was there one like inspirational event? Like you mentioned your dog had glaucoma. Like was that the
No, my dog had glaucoma after I was already in ophthalmology. I was not a lot of help to him. I don't think there's a lot of crossover skills between human ophthalmology. It can't be that different, but I don't know anybody who would be like, oh, I'll just like, I know people who are like emergency medicine doctors who have like put a stitch in their dog who ran into the bush or something. I don't know any ophthalmologists who have like, oh, we're going to take the dog back and get rid of its cataracts. When I was in med school, we had a mandatory ophthalmology rotation, which not a lot of med schools have.
It's like optional now, right?
From most places, it's an optional thing. And so it was not something that I really had much exposure to. It was not something that I was really thinking about. But what I've seen is a YAG capsulotomy, which if you're unfamiliar, it's the very simple after cataract procedure where a little bit of haze can kind of grow along the back surface of the lens, and you can polish it away with a painless laser in the office. It goes through the eye like light goes through the eye. Really simple. But we had one of like a teaching scope, so you can kind of look in, you see like just the dark background of the eye, and you see the little lasers going, and the patient just sits there, and they're like, oh, it's over, it's done. And that thing, I was like, oh, that is so cool. I want to do that. And now like a YAG procedure is like the easiest thing you'll ever do, and you don't even think about it. But it was something that when I saw it, I was like, oh, that is fun. That's awesome. It was over in like 2 seconds. The patient didn't feel a thing. They're noticing better vision sometimes like right away. That was something that it wasn't like only that thing, but I remember that in my like 1 week in the clinic, that was like, I saw that procedure. I'm like, oh, that's pretty cool. And that's what kind of pushed me to where I am.
Now, I looked at your training. You mentioned you grew up in Chicago.
Yep.
So you started in Chicago. You did undergrad in St. Louis at Washington University, correct?
It's mainly just called WashU, but when you say WashU, like people have no idea what that means. They think it's in D.C. They think it's in Washington State. It's like it's a pretty nerdy college in St. Louis. So that's where I went. But it was, for me, it was a pretty good fit.
But then you went to med school in Atlanta, right? Emory?
I went to med school in Atlanta at Emory. That's when my first year there, we got the Ebola patient like 2 blocks from where I lived at the CDC. And so like my family was like, oh, we're Emory. Like, I've never heard of it. What's that? And then a month later, like it was like, oh, like Ebola patient sent to Atlanta. And my mom called me like every week thinking that I was going to get Ebola. But that was an interesting start to my medical school, yeah.
So in Chicago, everybody wants to know, who has the best pizza?
I feel like deep dish has been kind of getting a bad rap recently. Maybe that's just my For You algorithm. But deep dish kind of got popular. Like everybody goes there, they get deep dish. And then there's like a sub response to that of like Chicago people being like, oh, deep dish is only like for tourists, or you only eat it once a year. Chicago tavern style, which is very thin, is the actual best type of pizza. I think that's fake news. I think the best deep dish is Lou Malnati's. It is, in my opinion, like the number one, my favorite. And it's kind of a chain. Like there's definitely multiple locations, but they do like a very good job. It's a little more expensive than some of the other ones, but I think it's my favorite by far.
So you and your wife both being eye doctors.
Mm-hmm.
When your brothers, your friends, parents, in-laws, when they have an eye question, who do they call?
So most of the time, it goes to me because my wife is a pediatric ophthalmologist. So basically, anybody who is an adult, they just go to me, and anybody who is a kid goes to my wife. That's kind of the split. Now, my advice is sometimes like a little more gruff, and her advice is a little more maybe calm.
That's why she's in the pediatric.
So sometimes like I'll get like my dad complaining about his glasses, and like my dad would be your nightmare patient. He described his eyes as like, as a child, before I knew anything about eyes, as like some crazy odd anomaly and that nobody could fix his vision. And then when I finally like got into ophthalmology and I learned what he just has one eye that's slightly nearsighted and one eye that's slightly farsighted and a little bit of astigmatism. And he thinks like he's like disabled. And so every single time he gets a new pair of glasses, he is going back and getting it redone. Like every time he gets a new pair of glasses. And so when he calls me, I've gotten to the point where I'm like, this is not a real problem. And like you're creating something out of thin air. But my wife will be like, oh no, like you could try this thing and you could try that thing and you can try this. And so he's now started calling her, but that's because she's still very, very nice to him because she's trying to get in good graces where I'm trying to give him tough love so he doesn't kind of piss off every single optometrist within a 20-mile radius of where he lives.
Isn't it kind of funny though, you went through all that training, very smart, you know exactly what you're doing in the OR, pure confidence. You could be doing a home improvement project with your dad in Chicago. At least this goes for me. My parents have a place up north. I'll be using a saw. My dad would be like, be careful. You want me to do it? I'm like, oh, I got it.
Well,
this is the power area.
Just this summer, my mom had like a big splinter, and it was like on her right hand, and so she couldn't get it, and it was like really deep in there. And so I was like getting it out, and my dad was like telling me like what I should be doing. I'm like, Dad, like I do microsurgery for a living. Like I'm just fine. You could stop telling me how to get this splinter out. I think we'll be good here.
Right. So I want to change gears a little bit. We have a lot of young followers.
Okay.
You know, some of them can be in high school or undergraduate studies.
Mm-hmm.
What advice would you give somebody that's interested in medicine or maybe ophthalmology, but they don't know exactly what path or how to go about doing it?
I wouldn't say like every single person you have to go to medical school. It's like the only career path. I think there's definitely some communities, some people, some families who like very much prioritize that. I think that's a little overdone. That being said, I think ophthalmology is like a really, really, really good career path. Anything in eye care, I think, is a really good career path, that you make a big difference, that you work with people who are motivated. It's nice, even though I'm on call right now, it's nice that like a lot of what we do is 9 to 5, and so you can still have a pretty reasonable life. If I'm talking to a medical student, I think that's a very easy conversation. You've already made the commitment to go into medical school. I would say at least take a week or a couple weeks to like see if you like it. Try to like volunteer or shadow in a clinic or take an elective. And if you enjoy it, then you kind of need to figure out like whatever your institution is, like you do need to do a little bit of research. You do need to like kind of make some connections and doing those things to make it possible for you to get in. And it's not for everybody. There are, for some reason, the eye freaks a lot of people out. Like when you probably feel this too when you go to the emergency room. There are emergency room doctors who like deal with gunshot wounds and stab wounds and like they're like total bosses in terms of like being able to handle anything. But then like someone gets like a conjunctival laceration and like it hangs a little bit out and they like are like almost nauseous. They don't want to go anywhere near it. So the eyes are not for every single person. But I really think if you're in medical school, you should look into it. But you do kind of have to start pretty early. If you wait until later, it is unfortunately just a little bit on the more competitive side. So you need to get your ducks in a row, do research, kind of get letters of recommendation. You can't just decide, oh, I'm going to do it with 6 months left of medical school. So just exploring it, considering it as a real option, because again, for a lot of medical schools, it's more like an elective. And if you don't actively seek it out, you'll never see it and you'll never get into it. Now, if I'm talking to like a 17-year-old, I think it's something to consider, but I wouldn't tell a 17-year-old to be like, oh, you have to do ophthalmology and then you have to apply to medical school and then you have to do whatever 8 years of schooling to like get to this job. I think you should at least be seriously considering like medicine and med school like at large before you just lock into ophthalmology. Where I went to school, there were a lot of pre-meds that I was friends with, and there are very, very, very few people who actually went into the field that when they were 20 years old said, oh, this is the field that I'm going to do. So I wouldn't take a 17-year-old and be like, oh, you got to do ophthalmology. But once you've kind of figured out that you might be on that medicine path, I think it's very much something that you should look into because it won't show itself to everybody. It's kind of a little more niche, but if you do like it or you're not grossed out by the eye, you like small details, you like doing microsurgery and having usually very, very good results, it can be a really awesome option.
Then you mentioned you like bird watching.
Yeah.
Like some people get into golfing, fishing.
Yeah.
How did you first get into bird watching and say, hey, I like this. This is cool.
My family was like very much like an outdoorsy family. And so I always say that everyone's like essentially a bird watcher and they just don't know it yet. And so like we would always go out and like we would like if there's like a bald eagle, be like that was a big deal and a fun day for us when we were kids. And then so I just enjoyed it and kept doing it. So I'm pre-COVID bird watching. I was bird watching before all of the other people were doing it before it got cool.
But it has to be a little bit of a love-hate relationship though, right? Like for example, I clean my car. It's great. Bird shits all over the windshield. It's the only time I'm looking for the bird, right?
Oh, okay.
I don't have many bad. I try to appreciate even like a pigeon. I try to.
He loves the
I do like a meditation on appreciating pigeons. If you look at a pigeon, they're pretty cool.
Well, we're putting you to the test. Amanda has a test for you because we know you like birds, and it's called Does Dr. Peters Know About Tweeters?
Okay, here we go.
They put this together, so...
This is how I got into residency, by the way. My interviewer was like quizzing me about birds.
Really?
Yeah.
I think he's getting them all. Okay.
Common loon. That's my favorite bird.
Wow.
Right off the bat.
Well, how does it see underwater, though?
Oh, my God.
Oh, don't get him started.
So in a human, like there is a like the zonules will change the shape of the lens, and so you can see from distance, and then as that changes shape, you can see up close. Loons will like prolapse their lens through their iris, and that lens bulging through their iris, it changes the shape of the lens, and then allows them to change how they see. And they need to do that because when they're above water, it's a totally different media, so it bends light differently. And then when they go underwater, to maintain their eyesight, they need to drastically change how their lens is shaped so that they can still focus.
Dang.
I want to ask you another thing, too.
Yeah.
I'm sure you have to call these in. I know that makes a very unique noise.
Yeah.
Do you have can you
Oh,
make
no.
it?
I can't do it. As a kid, we had like a little like a wooden thing that kind of sounds like a train, but it's like makes the like you blow into it and it makes the loon sound. I cannot do a loon sound, and I'm not going to try it.
All right, he's 1 for 1.
All right.
That's a northern cardinal. I don't have any cool eye. Right off the bat, I had my cool eye fact. I don't have any. Well, here we got a lot of birds, northern cardinal included, will have like blue jays have this. They have like a lot of black, but it's basically the equivalent of like a center fielder or a safety wearing eye black. It just absorbs the sun so that like a lot of birds are active in the day and they can see better.
I would have guessed
Oh,
southern
interesting.
cardinal.
Because they
Oh,
got.
my God.
That's what I would have gotten.
Well, you'd be wrong. Let's see if you can guess the next
Yeah,
one.
the next
and
one's
then
on
let
you.
him guess. Here we go. There's no shot.
Canary?
Goldfinch.
Isn't it canary yellow?
American goldfinch.
I mean, canaries are yellow, yeah.
That's close.
There's multiple
It's
yellow
honorable
birds.
mention.
That is a red-winged blackbird. These are in Michigan. These are the ones that, like, if you're in anything that has, like, any sort of field or marsh or, like, water's edge where there's, like, cattails, they just scream constantly.
They're kind of pretty.
And then that is a nuthatch.
A nut. Wow. Do we have more?
Oh,
It's Chicken Little.
Classic.
I don't think I've ever seen Chicken Little, the movie. Maybe
Really?
anyone have any?
Good watch.
no,
I haven't
don't
seen
think
it
I've
in
ever seen
years. I don't really remember it too much.
Do you have a favorite bird?
I really like a loon.
Really?
Yeah, loons are very cool.
What-
Could we just say that was 5? That was 5 for 5.
Yeah,
That was
he got
easy
them all.
5 for
He
5.
got them
That
all.
was 5. Do you ever get mad at the Canadian geese when they have wings and they decide to walk across the road with all 20 of them?
So you were talking about the love-hate thing.
Yeah.
The Canadian geese thing is one that is a little frustrating for me because there's just too many of them now, and they don't have good natural predation. So I do think there's probably some universe where like a hunting or something, because in a real world, like foxes and wolves and coyotes would be eating them, and there'd be a reasonable amount. And now that they've actually like made a huge recovery from where they were in the mid-century, there's just it's like white-tailed deer, except nobody's hunting white-tailed deer as much as they're hunting geese. So
Right,
there's
right.
just way too many. It's like actually a problem.
So there's what's called hot takes and debates. We had a lot of people that write in to our social media asking us different questions. Is rubbing your eyes really bad?
So I would just encourage everybody. You can YouTube it, you can Google it. There's a video online of an MRI of someone rubbing their eye and just watching the eyeball smash. And so that's not a real scientific answer, but I think if you watch that video of someone rubbing their own eye and you just see the eyeball kind of scrunching up into nothing, you'll not want to rub your eyes much anymore. But in terms of like why you don't want to do that, it just gives you more astigmatism, especially if you're younger. Once you get older, it's probably just, it might make allergies a little bit worse. It might increase a little friction. But if you're like less than 30, 25 and you rub your eye, you'll like change your glasses prescription. And sometimes if you have like a keratoconus, you could really make it bad. So in general, like especially after surgery, people ask like, oh, like I was told I can't rub my eye. Like if you're doing this and you brushing something away, that's probably not going to do anything. But there are people out there, and they will know who they are, that just out of habit, like someone will bite their nails, they'll take a knuckle and they'll just gouge it into their eye socket. And it really is those people who that cause us the most concern. Like if you're waking up in the morning and you have some blepharitis on your eye and you rub it off, that's not going to change much. But it's that kind of out of habit,
Like
out of
multiple times a
nervousness,
day.
just really there's eye rubbing and there's eye rubbing. The people who really get a knuckle in there and mash are the ones who are going to cause themselves the most problem. But I don't think that's not your average.
Plus, it
person,
increases
though.
the pressure inside your eye. So if you
Yep.
have a glaucoma patient, and
Yep.
I'm always shocked on how many people are eye rubbers. Then they have eye surgery. They have an incision in their eye, and they're like, "Well, when can I rub my eye?" I'm like, "Well, calm down. You have a cut made to your eye.
Yeah.
Don't rub your eye. That's what the
Yeah,
shield's there for."
they and I don't think they don't know it. They don't really even acknowledge that they do it until like you tell them that they can't do it, and then they're like they don't know what to do with their hands anymore.
Right.
It's an interesting phenomenon.
And dry eye, that's another big topic. You know, you have all these different things with clear eyes, Visine. They get a lot of marketing. Some people think that dry eye is just hyped up. It's not a real diagnosis, or is it truly an epidemic?
I think it is both. So I think mainly it is. It really is out there in big numbers, but I do think that like people will hear about it and they'll pathologize themselves. Like, oh, this is a problem that I have, and then it kind of gets fixated on, and in that sense, it becomes more of an issue than maybe it really is. But there's a lot of people out there that have dry eye. There's a lot of people out there that have at least like kind of mild to moderate symptoms. Like they go to drive and they're focusing and it's winter and there's the hand warmers blowing at them and it gets blurrier. I think there's millions and millions and millions of people who have at least like that level. And there are definitely things that you can do that can make that a little bit better. It's a chronic issue for the most part. But like I think there are people who have kind of mild to moderate symptoms who might not even be thinking about it, or they're like, oh, this isn't the worst. I'm not going to do anything about it. And that's fine. But if it is bothering you and you want to try something like a drop, or you want to try something like a punctal plug where we can help keep more of your natural tears on the eye, I think in some ways it's underdiagnosed because there's a lot of people who I think would benefit from some of those kind of early interventions who just don't even know that it's something that's out there.
What you mentioned, like there's some people that just, you know, like in July, they do great in Michigan, but maybe January, you know, with the heat blowing on their face, they're going to dry out. I did see a stat that there was like truly dry eye disease. It's like 38 million Americans have dry disease. And I think it could even be more like the mild ones, like the, you know, in January, Michigan. But of those 38 million, only 10% of them are on a true like prescription lubricating drop. And I think that's where like Visine and Clear Eyes is really kind of taking advantage of that market.
Yeah,
too.
and I do think like I'll see some people and they'll come in and like it kind of sounds like a little bit like it's probably not a pink eye, it's probably not regular dry eye, it's probably something exacerbated by the smoke coming down from Canada this summer or the allergens, and I'll try to like give them some artificial tears or maybe even give a little mild steroid drop for a short course, and they'll come back like, oh, I feel so much better, thanks doc. And I was like, yeah, but like also like maybe if we just waited 2 weeks anyway, this might have just gotten better. I think there's a lot of people who are in that realm, but there's definitely people who have a lot of chronic issues and just need more.
Do you think contacts could make your eyes more dry? Because I feel like for me, when I wear my contacts, I'm always like, oh, I just want to take them out. They feel so much more dry than glasses. But
Yeah, I think for sure there is a component, and everybody's a little different. I used to be someone who wore contact lenses a very high amount of the time, and I don't have bad dry eye at all, but it was like to the point where, especially later in the day, they would just get a little more uncomfortable, and I've just kind of switched because it's a little easier for me. But I do think certain people in certain eyes, you wear those contact lenses and they just either they rub too much or a little bit of allergens accumulate on them, and that kind of mixes two problems together. I got 70-year-old patients who have worn contact lenses for 6 decades and they look amazing. And then I have 20-year-olds who like all they want to do is just, please, I want to wear my contact lenses, and you just can't find a way to get them comfortable.
Right. I think it's gotten a lot better with the 1-day disposable lenses
Yeah, that's what I
before,
use.
and then people get a 2-week disposable or a 1-month disposable, and then they would wear that lens for 6 months. And then they start sleeping in it because their eye doesn't feel bad. And then it
And then
collects
it
with
cycles.
protein and
Yeah. It gets just all this stuff gunks onto it, and then But I think if you how breathable they've got the contact lenses and you don't abuse them, you're actually getting them fitted appropriately. I think they've just gotten so much better than where it was a couple decades ago. But even then, with all the advances and trying to treat things, there are some people I think you just have to have a conversation where is it worth it for you
Right.
to keep battling this sensation with the contact lenses?
And the solutions have gotten a lot better. Years ago, the solutions weren't as good, and you would see, I think, more eye infections because the solution wasn't killing any bacteria in that in the well of the contact lens.
Ulcers are the worst, but like I feel like in the last few years, I just see less. Like
Right.
they're out there for sure, and maybe it's just people kind of know about it. There's always the horror story of like, oh, this person went in a hot tub and they went blind. But I feel like I don't see as many as I used to, and when I see them, they're thankfully smaller. Again, this is not a recommendation to overwear your contact lenses at it by any means. But I do think that thankfully the technology has gotten to the point where it's just a little more breathable, a little less irritating.
Yeah, and I had a few at the hospital when I was on call that everyone kind of thought it'd go away. Something's in there. It'll get better. And the next thing you know, it incubated in there for like 3 or 4 weeks, and it's now a massive ulcer.
Yeah. I mean, there's definitely ones that'll show up out of the blue, but it's a lot. I think it's a lot of people who either just like how busy they are in their life or their personality, where their body is trying to tell them something, and they're like, I just don't have time to go get a new lens, or I'm down to my last pair, and I'm just going to ignore it until it hits you in the face.
What's your thoughts on telehealth?
I don't love it. As an eye doctor, like I get a lot of people that I know who will send me stuff, but specifically with eye health, there's very few people who get a good in-focus photo of the eye. And one thing I like about my job is that you can really get an answer most of the time, just like getting a couple tests and looking at the eye, and very little of that comes over on the phone. So for certain things or in certain situations, it can like buy you time or get you maybe like a decent answer. But in terms of like, say, psychiatry, where you can do almost the entirety of that field of medicine over the phone, and I don't think you're losing much, I don't think for any person, you could get any sort of comprehensive eye care in the long term for telehealth. So for people who need it, or like there are just certain things that are very straightforward, like it's a mild sty, it could be reasonable. But a lot of the things you just can't know. And there are so many eye conditions like macular degeneration and glaucoma. Like I am convinced that all of the patients that have great vision are always the ones that end up having the worst glaucoma because they never come in and get seen. For people who have contacts or have glasses, just as a nature of doing that, they're actually getting their general eye screening. But for a lot of the patients who have great vision, that sty that they have when they're 30 might be the one time that they come in and you actually check their pressure.
Right.
And so I don't love the idea of offshoring everything to like virtual and just take a photo of it, because there's just stuff that you're going to miss. And maybe that sty is the thing that brings you in, and that's your visit to actually get eye care. And you're not looking back 20 years later and being like, oh, maybe I missed glaucoma that was starting.
I agree. I care, like a sty, maybe you could do something like that, but you can't measure a visual acuity accurately. You're not going to see the optic nerve accurately. I don't know how you'd see that optic nerve at all.
I think as getting an answer or buying you a little time, but like I think any telehealth and eye care needs to be like, this is probably the answer. You could start with this, but we're like, we need to see you in real life.
So Amanda has some YouTube videos for us that we're going to look at, these eye injuries reaction videos.
Okay.
So
what level of gore? This is all
I'm
YouTube.
not
so
sure.
I
I
assume
did
we're
not.
I will tell
I
you
did
the
not
best thing is
select
watch
these.
Amanda's face for it.
Well, that's too much.
Before we pull this up, you know how on at least on my iPhone, when they like, I don't know if it's AI or who's doing it, but they try to like group your photos for you, and so it'll be like happy
by
memories.
person, yeah.
I definitely have had a couple times it'll be like eating out or like great meals, and it'll be like, oh, this is lasagna and this is like a burrito, and then like
You have an eye laceration or something?
It's some like
Oh,
eye laceration that I'm
terrible.
taking a photo of. Like that's not what that was not a great meal.
That's where
so
AI
gross.
failed.
Yeah, I have some. I usually try to delete them so I don't see them ever. But there definitely have been some very grotesque things on my phone. So I don't think YouTube's going to show me any of these, but we'll find out.
Yeah.
I guess.
Yeah, I've been working on Dr. Jaber's PowerPoint for the symposium, and he has some videos in there, and I'm like, Dominic, you have to do this. Like, I cannot even look at
there's
his
some
presentation.
there's some if you're not kind of built up a little bit of resistance to it. There's some.
Even he was struggling, but okay. We'll see what's on here. I'm not sure.
You did not watch any of these, right?
No, they picked them, so it's a variety apparently.
Acne stuck in the eye. It's gone.
Is her eye gonna pop out or something?
Does she have a scleral contact lens?
Is she looking for a lens? I don't know.
They
Oh, she's got a colored
But she
contact
has to
lens.
because I would
That's
say the right
happened to-
one.
ugh.
Yeah. Say the right eye.
That's
is
happened to me
completely
before.
different.
It like slides
I
back.
think I spent almost 10 minutes looking.
Ew. That's not terrible, but do they always come back? Like, let's say it did get stuck.
There's no behind your eye. So a lot of people will think it went behind my eye, and it's like,
Went
oh,
to
it
the side.
fell like between the, I don't know, like a grate, and it's gone forever. There's no behind the eye. Farthest back, it's going to be like behind the lid or like in the lower lid, and you flip the lid and you can find it. So I definitely have people, and you must have the same thing, where you can definitively see someone in the clinic and look at their eye and be like, there is no contact lens here.
Right.
And they will not believe you. They'll go, I feel
Like
it.
it's
It's
stuck
in there. And
somewhere.
I'm like, no, that's the irritation that you're feeling. But
Some
people
of
will, what I thought is people will take their finger
Oh.
and go
Yeah.
inside their eyelid and try to fish something out that was
That's
never there
gross.
in the first place, or it just fell out and they missed it.
I've
I think
had
at least once every month or so I get someone like that.
For sure. And she had a color contact lens. That would be easy to see. But sometimes
Yeah.
they get folded up. And,
Yeah.
the light we're using with the slit lamp is kind of just going straight. So, as the eye curves, sometimes it gets folded up and it's way back there. And
Yeah.
sometimes they can be difficult to find.
What's the most you've seen for someone having their
I think
eye at the same time?
It was 3. I was talking to Dr. Williams about this. It was 3. There's that video that one doc pulled out like 20 something.
I think I've only had like two or three, but I've known people who have been like, no, there was like
Yeah.
6, 7 in there that the person just kept putting in and in and in and in.
Does that like distort their vision though?
Yeah, well,
Like,
that's what they're
wouldn't they
coming in
not
for.
be
They're
able to
like,
see?
Yeah, because they're adding the prescription. They're just they're stacking the
yeah.
contact lenses. And they're like, my vision's blurry. So when they come in, then
I wonder why.
you take it out. They're like, they say, hey, my lens is out. And then you're like, no, it's not. And they take it out, and they're like, oh, there's another one.
Yeah, there's usually some sort of, they're not processing other things in their life so well often.
Blurry. The kid gonna like hit her in the eye.
Oh!
No.
Baby fingernails.
That is-
There's a lot of baby fingernail injuries, but that's like way up
Should
there
it be
on-
that easy to pop the eye out like that?
It popped out pretty good, too.
Like that seemed like it was too easy.
Just, yeah, I'm like, that was quite proptotic there. So
Yeah.
Well, here I won't. I'm not gonna look.
probably has
Oh,
like thyroid eye disease, too.
The eyeball does not
Yeah.
pop out of the head though, so that
so
is.
it can't like fully.
I mean, in theory, you, if you really wanted to, you could, but it's you can get proptotic where the eyes come a little farther forward, and even there are diseases like thyroid disease that'll cause that. African Americans in general, their eye socket is a little, just anatomically, a little shallower. It doesn't have as much depth, and so especially if you push just right, you can kind of get the eye doesn't come out, but it just comes out a little bit farther, and then the lids. That's the big thing. The lids start to come on the other side. So it looks like it's coming out. And then the other thing is people lose their mind, and it becomes kind of like a Chinese finger trap, because the more you squeeze, the more your lids want to get on the other side. And then it doesn't, like you're basically clamping it from going back. So you really just need to like take a breath, relax, open, and then it should kind of go right back. But it's a very scary thing for people if they ever have that happen.
I'm looking at this video. I have no idea. I'm trying to predict what's going to happen with her.
Eye tattoo?
that's what I was thinking.
That's my guess. People tattoo their sclera.
Which is
I think
crazy, but
Or it's like the context that like the bassist from Limp Bizkit had. One of the two.
Can you
How
wait.
the hell am I supposed to get these out of my eyes?
No, is that her? I don't really want to see that.
I can't grab it.
Are you supposed to use tweezers like that? Is that a real thing?
This hurts so bad. I can't get it out.
What?
Oh, I got it. I got it.
I don't know why
Man.
she's using the forceps.
That's what I'm saying.
Yeah.
I feel like that's not a good call. I don't really
Yeah, I would not
feel-
recommend.
I've honestly never seen a contact lens like that on any
like that
patient.
covers your whole eye.
Yeah, I was wondering, is that something from a different country? That
I have
I
no
don't
idea.
recognize that. Not recommended. Whatever that was, I
Don't
wouldn't
do
recommend
that.
any component of that.
It's like tweezers.
Did she
Yeah,
have it
but
in there
why
just for,
would you? I guess she has long nails, but like, still.
Like, what was the point of that? It was like cosmetic. I want to black out my sclera.
Yeah, I think so.
Yeah.
That's what the kids are doing.
Stylish.
these
It's
days.
just, it's a new trend.
All right.
And I figured out how to do it. You're not supposed to move your eyes back, but to the side, if that makes sense. So you pull up and down, and then, well, you look to the side, and then you blink. So you look here, and then you blink.
Why would
And that should get it out.
Can't you just take it
That
out?
worked so well.
Do you use that?
No. No, they typically just take it out. But
I feel
we
like
were.
you couldn't even do
This
that.
was like
I'm
a
not
trend I
gonna
felt
try.
like a year ago. I think
Yeah,
Dominic,
we
you
saw a
tried
video
doing it.
about-
Did it work for you?
I feel like that's more work than just like
Yeah.
taking it out. But
I think once you get to the point where you're actually good at putting contact lenses in, kind of by definition, your reflexes are a little dulled at that point. You can usually just take it
Take it
out
out.
normal.
I don't wear contacts, but if I did that, it would just probably fall on the floor, right?
if it's
I
dailies
would-
though,
Catch it.
doesn't matter.
It's true. Look at you, Manny. You're learning so much about contacts.
Wow. Is it gonna show something? 'Cause I.
Oh, wow. Right into her eyes. So many pieces of it, too.
Just dirt off the ball.
Oh, it like hit.
Oh,
Wait a minute.
It went
Wait a
from her
minute.
cleat, and the ball hit it off of her cleat.
Are you kidding me?
At first, I thought it was off of the ball, and I was thinking she would have felt that, but that dirt came off of her cleat, and then
pretty
it.
impressive.
would hurt.
I'm like, what's the chance of hitting that piece of dirt? But I like how they have a meeting at the mound. Like, why not go to the dugout and maybe have it checked out?
Does that stop the pitch clock?
I don't know. I don't know how softball works.
Me.
Amanda, you
either.
played softball. Does it stop it?
I did not.
So do you think she went out to the pitcher and be like, hey, what's going
I
on?
did not play softball.
Do you see anything?
Send him to McClare McComb.
Right. So some new hot topics in eye science, new upcoming, medicine. So I just heard that Alcon is releasing a new dry eye drop called Triptyr. So I know, there's Restasis, there's Cequa, there's Xiidra. So we have these other prescription medications. So there'll be one more tool in the tool bag. Any thoughts on that or?
I like having more options in terms of dry eye because there's a lot of things in this space that are good options in like the anti-inflammatory prescription drop. A lot of patients will think that prescription drops are just a better version of what they get at the drugstore, and I try to tell them it's kind of a different beast. The drugstore artificial tears are usually about tear quantity, giving yourself more tears on the eye, and then there are some components that they're maybe a little bit, the actual tear itself is a little better. But with a lot of these anti-inflammatory medications, you take them like you take a blood pressure medication twice a day, every single day, and over time it helps you make better tears. So they're a little less inflammatory, they're not so irritating, they're just higher quality. But a lot of the different chemicals in these drops, some people will do a little better with one, they'll do a little worse with another, and it just will sting them a little bit too much on installation. So I do like having more options for anti-inflammatory drops, especially if someone's like more tolerating of one than the other. It's really nice to have different options.
I tell patients, I'm like, there's no magic eye drop that's going to eliminate your dry eye. This is going to be a chronic condition that you're going to deal with. But having more options is,
Yeah.
like you mentioned, like someone may do good on one drop, and then you try it on the next patient, they don't do as
Yeah,
good.
for sure. There's not an algorithm that you can follow that like, you just work your way up the ladder, and if you just do that, it's going to be easy and everybody's going to be fine. It's like some people will get this and you'll think it's going to work amazing, and it's like that didn't do anything and they hated it, and you do the punctal plug and you don't think that that's where the real problem is, and they're like, oh, no, I'm way better. So it is very much we're going to kind of go one step at a time. We're going to try things and see what works for you. But dry eye, yeah, is definitely a process. So more tools are always better.
Yeah, like I tried Cequa, which is prescription, right?
Yep.
And I liked just the refresh, like over the counter, better
Yeah.
personally. So you never know.
Cequa is kind of like a Restasis. When Restasis first came out, the carrier of that medication was Refresh Endura, and you could buy that over the counter. And then they kind of got rid of it because Refresh and Dirt was a good lubricant. And so they kind of got rid of that to make you know, purchase the Restasis.
Or Restasis.
I'm kind of interested with this one because Alcon makes this medication. And Alcon is a big player in eye care.
Yeah, for sure.
And this is not like a no-name company. I have not tried it on anybody. It's not out yet. It's literally being launched right now. But according to the data, they're saying that they had increased tear production even as early as day one. And some of these other medications, when you put it in, you know, they're saying you got to give it 2 to 3 months before you know if it's even working.
That's definitely for a lot of the other kind of anti-inflammatory prescription drops. There's definitely usually an onset window where you need to kind of just stick with it and like fight through the first few weeks until you even know if you're going to be one of those people who responds or not. So faster is definitely better.
I tell patients too, like, you know, if you cut your skin and somehow, some way that magically just kind of heals over, your cornea doesn't have any blood vessels. You're not getting that healing factor right to the surface where you need it. And just sometimes you just kind of manually lubricate the eye. I was talking to Dr. Jaber, who was our corneal specialist. You know, I sent him a patient. I'm like, I've tried all these different things. He's like, you know, when you've tried everything, he's like, there's not many more things I can try. He's like, sometimes patients just unfortunately have that bad of dryness. They do need to put a drop in their eye every hour. They're just bone dry, and there's different systemic conditions that can create more dryness. There's a lot of medications out there, even like cancer medications, that just dry out the eye tremendously. The medication's saving their life, but now you have this horrific dry eye too. Yeah. So would Tripteer put a dent in those patients? Probably not, but
I haven't found a great way to, at least that I think, to like get it across. But a lot of the people that have dry eye, I think they give up on things a little too quickly, because a lot of the times I think these tools that we have are like straws on the camel's back, and a lot of these different medications and strategies work differently. And I do think people will like try one thing and be like, oh, that didn't work for me, and I'm not going to do it ever again. And then they'll try a punctal plug and like, this didn't do anything, take it out. And it's like, well, maybe you need the artificial tears, and you need the prescription drop, and you need the punctal plug, and you got to be consistent with the drops. And like, you do all of 4 of those things, and they're all stacking up, and you start to get some results. But that's the reason that dry eye is so frustrating. Like, you can do something that's helpful, but it's just not breaking the kind of ceiling of getting your symptoms more under control.
And the trouble is, like, even when this medication, let's just say this medication works, prescribe it for a patient. And that's probably one thing that you probably thought about in medical school, like, all right, cool, and this is the medication, I prescribed this medication for this patient. But then you find out in reality, patients don't have insurance coverage for it. It's on the formulary. Then you fight with that game. You do these prior authorizations, and you know, some medications can cost patients $500 a month to be on.
I'm so lucky that we have the staff that we do, because it's just like the way that I try not to put too much of my brain space on like what the price of things are, but so many of our like technicians and scribes are like very good at being like, oh no, they have this insurance, and so this new medication will be not covered or will be covered. But that is a frustrating conversation to have, where like, yeah, I think this might help you, but it looks like your insurance coverage isn't great. And the problem is, nothing in medicine is a guarantee, but like especially dry eye. So people can spend all this money, and like it'd be very normal for them to not notice all that much difference that happens all the time. So you never like to have that conversation when you go to pull up the price and it's like, oh yeah, it's not covered, and it's going to be $600, and it's a medication that with a chronic condition you might need to keep taking.
Right.
So
yeah, different than an antibiotic where you may be on it, fixes it, you're done. This is going to be month after month after month.
I use that exact analogy when I'll have someone who's like, I just want to try anything. I'm like, just so you know, like, this is not like you're taking something for a skin infection for a week and I'll pay $600 and then I'm done with it. With these drops for dry eye, it's like if it's very difficult for you to afford the first month, then maybe it's just we got to figure out a different solution, because I don't want, if it's difficult the first month, it's probably still going to be difficult the second month and the third month and the fourth month. And like, can we try something else or bark up a different tree to get you a better answer?
And what's difficult, people will buy over-the-counter artificial tears, and they can be $20, $25 for an artificial tear. And, you know, some patients have trouble with the $25, a bottle for that. And then you try to go down this road, and this is going to be potentially multiple hundreds of dollars.
Yeah.
How do you tell them to try that? So that's a difficult thing. Like, the science is there. Hopefully it works. Hopefully it gives you another tool in the toolbox. But you got to play the insurance game.
Yeah, exactly.
And what do you think about, like, you know, you mentioned like MIBO?
I like MIBO. MIBO's out. MIBO is a newer FDA-approved drop for evaporative dry eye. So instead of like not having enough tears or trying to get the eye to make more, you basically try to lock in the tears that you have. So MIBO is amphiphilic, which means kind of like soap. It doesn't feel like soap, but part of it dissolves into water, part of it dissolves in more like an oily consistency. So one part of the drop kind of absorbs into your tear film, and then the other end is like a glob of oil, and it kind of lashes like an oily component on top of your liquid component of your tear. And so for like patients who they focus on anything for like 2 seconds and their eyes dry out, they go to drive and their eye dries out, they're outside for a second in the wind and a breeze blows past their face and their tear evaporates. I think for those patients it's very helpful, and it's kind of a newer one in that realm. There's not anything else out there that is specifically designed to do that. But again, just like we were talking about, the coverage has been kind of hit or miss depending on what you have. And so if it's $600, is that a reasonable option? But I definitely have had some patients who have had some more recalcitrant dry eye where I've had really kind of like surprisingly good results, where like the studies will say, yeah, on average it's taking 4 weeks or so to kick in. But I've definitely had patients who just immediately are like, this is a better drop than anything that I've ever been on. And if you had to guess what the science is, they're probably just have a very, very wimpy evaporating tear film. And once you protect it, it gives them a lot of relief. So I would love to see more insurance coverage because I've had pretty good results with it. But again, it's a tool in the toolbox.
I agree. I would like to use it a lot more, but it's sometimes hard to get coverage on it. And like one of the side effects of trip tear, it burns when it goes in, but that's like majority of them, like Restasis burns, Xiidra burns. Have you ever put MIBO in your eye?
I have.
It can't feel anything.
Yeah, you don't feel a thing.
It's like silk is my best
I
analogy.
felt it.
Yeah.
It's kind of oily.
If you don't see it going into your eye, at least for me, I'm like, you wouldn't know it went into your eye.
Like when you meet with the reps, like they're like, because it is a smaller bottle and it comes out really
Like
small.
They call these micro drops, yeah.
That's the other thing. There's people who will see and they have like, that they have bad dry eye, but they haven't tried anything. And like MIBO, there's like I think probably a skill and a dexterity component to getting MIBO in. Like you don't want to be wasting an expensive drop if
Right.
you're like your rate of getting it in the eye is 1 in 5 actually makes it like that's if you're spending out of pocket that's going to go quickly.
Yeah, and it is a tiny bottle, so you're right. If you're arthritic and like it's going to be difficult to squeeze that bottle.
I feel like I've been getting that more and more and more because America is just getting a little older. But like people who even with like the small latanoprost glaucoma drops, right. They're like, that's just the bottles. Do you have anything bigger? It's too difficult for me to be using these small bottles.
Yeah, but that little bottle, I heard it holds over 200 drops though. I forgot what the exact number, but you get this little dinky bottle. And that's the trouble too. You're like, oh my God, I spent all this money on it. It's like a tiny little bottle.
Yeah, it's not one of those things where you're like, oh, I'm like when you see it, like I'm getting my money's worth out of this little tiny thing. Me and my wife will watch Jeopardy on TV, and I think the commercials are geared to people in a certain age demographic. And there's the macular degeneration ones and the thyroid eye disease ones. And I think both of those medications can be very, very good, but they're billed on these commercials as like these cure-alls. So one of them is Tepezza, which is like an 8-week infusion medication that you like go and sit in a room and they give you a thing and it can have side effects like hearing loss and like spike your blood sugar. But on the commercial, it's just like, do your eyes itch? Like, talk to your doctor about this medication. And like, it's a great, great, great medication, but it's used for like people who have tons of like vision threatening swelling behind their eye that you can get with thyroid disease. Their eyes start to cross from thyroid eye disease. And like the old fixes for that were like radiation or like chemical medications or surgeries on the eye socket. And like, of course, an infusion, if that works, is a great option. Yes, thyroid eye disease can like also cause some dryness and some itching, but I think you should try at least a couple things first before you're kind of rushing into an 8-week infusion course. So that is one of the commercials that I see on TV. And then the other ones are all the dry macular degeneration injections.
Yeah, yep.
So Syfovre, Izervay, like they're reasonable, but they only are doing for like geographic atrophy as far as I understand. And like their rate of reduction is like a reduction in growth. So you're not fixing anything. You're signing up for injections and they do come with some risks, but like you might have grown 100% if you did nothing. And then on these drops over a year, over 2 years, maybe you're growing 75% of that 100. So it's still worsening. It's worsening just a little slower. And then it comes with kind of some risks, all the risks of doing an injection into the eye. And so everybody in the commercial is like driving around and happy in a convertible. It's a much more nuanced conversation than like we've cured dry macular degeneration. Your doctor just hasn't brought it up with you yet. I do think there's a lot of promise there, especially for certain types of patients who are like holding on to one last little spot of vision. But I don't think like the sunny atmosphere of the commercial is like the breakthrough is still not there with macular degeneration.
Like Amanda doesn't know this part, but there's wet and there's dry macular degeneration. He's talking about geographic atrophy, which kind of is that dry category, which is in the dry category. We currently are doing injections for wet macular degeneration.
That's been around for years and years now. Yeah.
And those are definitely indicated. So absolutely, if those patients, and the same thing, it's not to say you're curing it, you're trying to stabilize the retina. But the commercial he's talking about, everyone's smiling and they're like driving into the sunset. With geographic atrophy, you essentially get an area of your retina, the central retina, that it's
right
just
where you want
thinning out essentially. And the goal is when you do this injection, if you have this much of a blind spot, can you prevent it from getting this big?
Yeah.
And it still grows. So with the injection, like if you had your center vision right here is blurry, like let's say if you did nothing in a year, it's going to go to here. It'll still grow on average, but it just grows a little less. And then it does come anytime any injection has infection risks. That specific one comes with, I think it's like a 10% risk in that ballpark of actually going from the dry to the wet macular degeneration. And so there is a patient who has dry macular degeneration in both eyes, and they've kind of watched their first eye go away, and they know now they've kind of seen that one go, and they know that like, okay, I have this little patch of vision that there's kind of blurry spots around it, but like right here I see very, very well. That is like the patient that I think kind of can make an informed decision. They get like, I have this little tiny spot, and I've kind of watched this other one change.
This one's extinguished.
Like I know what it can do. I know the pros and cons. And I've seen what happens to my other eye. That, I think, is the patient that with these geographic atrophy injections, like could very well be like, that's a decision and a risk profile that I want to make. Like the notion that you have some drusen that is dry on your macular OCT, and like, oh, I'm gonna go get this injection. That's just, we don't have anything yet that can stop macular degeneration in its tracks. Hopefully, at some point, but.
Yeah, hopefully one day. Like years ago, they were doing like real phoresis. So essentially, you're doing an oil change. You're taking your blood out, go through this filtration, put it back in. People were spending tens of thousands of dollars. It was never FDA approved. I remember going to Canada for it. It was kind of a neat thinking.
Yeah, and that's the thing with some of these commercials. That's the thing that I worry about, because it's you have such vulnerable patients, because of course you want to do anything that you can because it's your vision, but like there is pretty much everything that's out there for these like severe conditions. There's some sort of trade-off or kind of risk tolerance that you have to try these things, and there's really not anything that just rewinds it all back to nothing, unfortunately.
It would be amazing if there be a pill, hopefully. A drop, an injection, whatever it should be, if you can kind of get that vision back. I mean, thank goodness there's the anti-VEGF medication for wet macular degeneration. Yeah. Because that's relatively newer technology as well.
That's a newer thing, and I mean, that was, again, there are people who are like still functional that if this was 20 years ago and they had the wet macular degeneration, that would have just totally destroyed their retina. So that is a gigantic step in the right direction, but a cure, I think, is still a long way away.
But even kind of like how you're talking about dry eye, it's not like you're going to get one injection or two injections. And there's patients that have dozens or 50, 100 injections over the course of years that keep their retina stable.
I don't know if you saw the younger gentleman. I did cataract surgery on him. He probably had a myopic neovascularization in addition to some macular component as well. And I think Dr. Valise had done like dozens and dozens, if not like hundreds of injections.
The guy who made him the shirt?
Yeah, there's Dr. a guy, I think it was on Facebook, the guy made him a shirt, and I forgot the exact wording, but it says, I've been with Dr. Valise for 200 shots.
You probably have the same thing where you see somebody and like you're not a retina specialist, I'm not a retina specialist, but you kind of know where this is going, and you're just trying to
you have a patient who's maybe a little bit more anxious and you're trying to walk them through it and they're like, okay, yeah, I guess I'll go and get a shot. I'm like, well, it's almost certainly not going to be just one shot. We'll it's book 3 for probably the next 3 months. And then we'll maybe try to stretch them out a little bit, but this is not going to be a one and done thing.
It's my worst nightmare.
Well, Dr. Peters, thank you for coming out. This has
Thanks
been
for
a
having me.
great conversation. I think it was quite insightful on a lot of different topics. So I appreciate
Should
your time.
we do episode 6, just bird ophthalmology facts
Yeah.
for
Because
2.5 hours?
I needed to do a lot more research because I really wasn't helpful. I didn't know the loon. That's all I had.
Okay, there you go. That's
next-
a start. That's how it all starts.
But the next time you come back, I want the noise.
Okay.
You got to try.
Okay.
All right.
All
Thanks,
right.
guys.
Thank you.
Thank you.